So we look at the anatomy of the ankle. We're going to look at both the lateral aspect, which is often the case that we'll see with the inversion type of injury, primarily the anterior talofibular ligament that you can see on the diagram there, as well as the calcaneofibular ligament, and we can see how it's demonstrated here in the back by the arrow. There is a posterior talofibular ligament, but it's not affected as often, but can be. Then we're also looking at the medial aspect of the ankle and the deltoid ligament, which fans out from the medial aspect of the tibia down to the tarsal bones in the foot. So keeping both of those areas in mind, the other thing we want to know is the mechanism of injury. And here is a clip from Pete Sampras, a tennis player, in the 1995, watch his right ankle, Monte Carlo competition. That was the easier one I was going to show you. I didn't want to show you a more difficult one. So when we look at that, it's nice when we're there and we can see what happens. Many times the mystery is in the history, talking to the patient, finding out how did it occur. The most common mechanism is the one that we see with plantar flexion and inversion, as you can see demonstrated here, looking primarily at the anterior talofibular ligament, also called the ATFL, the most frequently injured. Sometimes you can get a combination, both the ATFL and the CFL, the calcaneofibular ligament, and last but not least, the PTFL can be involved. But there's another mechanism of injury that we've come to recognize more and more as a problem case, and that's the dorsiflexion injury when the red flag goes up. And that places the widest part of the talus in the mortise, and it's what we've come to call the high ankle sprain or syndesmosis tear. And Dr. Klein had talked about some of the surgical consequences that we see in terms of what will transpire as far as that membrane, and I'll go into that just from the ankle sprain point of view. So we're looking at the ligaments involved being the anterior tibiofibular ligament, that's a little higher up in the ankle region, as well as the posterior co-ankle ligament in that area, and the interosseous membrane, which is basically, if we're looking here, here's the interosseous membrane that Dr. Klein had indicated on that x-ray. And what happens is the lower portion is somewhat thickened, and it composes the interosseous ligament. We also have, as I mentioned, the anterior tibiofibular ligament, and there's this posterior counterpart. And what usually happens is the athlete is running, the foot is in dorsiflexion, but the torso and the tibia are internally rotated. So that foot is planted on the turf or whatever surface it is, and something's got to give, and it's usually these ligaments as well as perhaps the interosseous ligament. So the x-ray findings, when we're looking at it, you don't necessarily have to have a fracture, but you also want to always check for that. But you would see a widening of the gap. Early on, you can see that gap between the medial malleolus and the talus, and later on, there's a possibility that there can be some painful calcification in that area, and this may require surgical resection. This could be the case that it was missed. It was treated as, oh, it's just an ankle sprain, and it was not, simply just that. So we look at clinical examination. We want to examine the individual's ankle. Where's the swelling? Where's the bruising? Sometimes they come in 10 days after because they thought it would get better. So you want to rely on the history. You want to see in terms of what the mechanism of injury was, and does that correlate to what your clinical findings are? Always remember to compare to the opposite side, both on inspection as well as when you do some specific tests. We do have some specific tests that we use for examining an injured ankle. There's the anterior drawer test, and that's to assess the anterior-posterior translation of the ankle. Basically, you grab the, well, not grab, you grasp the heel of the individual, and you're going to anchor the other hand on the lower aspect of the leg, and you will have a little bit of a distraction anterior, and you want to see how much of a distraction there is. And certainly it said that if there's more than 5 millimeters, you're looking at some disruption perhaps of the ATFL, as well as looking at the anterior aspects of the deltoid ligament. Then we're looking at the Taylor tilt test. It's an inversion stress to the ankle region. Once again, you have your hand grasped by the heel and you go into an inversion position. This is testing for the CFL, the calcaneofibular ligament, and perhaps also mid-substance of the deltoid ligament. Abnormal is considered 10 degrees greater than the opposite side. So it's nice to be able to have an opposite side to compare it to, but once again, remember, find out what the history is of the opposite side as well that you're comparing it to, because perhaps there was a remote injury on that side. The syndesmosis squeeze test is what we're using for the high ankle sprain, one of the tests that we use, and basically there's compression to the mid-calf region, as you can see in this diagram, and this will elicit pain in the ankle region, lower down. This can indicate that there has been some disruption of those ligaments that I had shown you down between the tibia and the fibula, but there can also be a fracture of the distal fibula. As Dr. Klain had mentioned, be on the lookout for a fracture higher up, the mesonode fracture. So you need to palpate the entire length of the fibula.